Autism spectrum disorder. So I want to start this out by saying that the research on autism is growing profoundly. And so the information from your textbook is relevant for what you need to know for the boards. But if you have an interest in pediatrics, I would encourage you to look into some autism spectrum disorder continuing ed courses because they're finding out a lot of things at a really fast rate in regards to autism. And so the research I don't think is as up to date in your textbook as what exists in our real life. So jumping into what is autism spectrum disorder, it's a complex neurodevelopmental disorder that has a developmental disability or is defined with a developmental disability. It's characterized by difficulties with social interaction, communication, and repetitive behaviors. It's caused by differences in brain development. It is associated with genetic disorders, and it is the most common diagnosis in the United States. The Center for Disease Control and Prevention data says that 1 in 59 children have autism spectrum disorder, and I would argue that that number is one of the ones that's evolving with the research that's coming out. All ethnic, racial, and socioeconomic groups are affected. The textbook says it's 4 to 5 times more common in boys compared to girls, but current research makes this debatable. I do think that it is still more prevalent in boys than girls, but I do not think there is that great of a ratio in the current research. The average prevalence throughout the world is 1 to 2%. 1 in 6 children have a developmental disability in the United States, ranging from mild to serious, including speech and language, intellectual disability, cerebral palsy, or autism spectrum disorder. So the DSM-4 had autism with different subcategories, but when we jump ahead to the DSM-5, which came out more recently, the DSM-5 took all of those subcategories and grouped them together as autism spectrum disorder, with social communication disorder and Rett syndrome being outside of those. So the DSM-5 diagnostic criteria, again, those previous subcategories were all grouped together under the broad term of autism spectrum disorder, and patients need 3 deficits in this first category and 2 in the second to meet the diagnostic criteria. So the first category being impairment in social communication or interaction, meaning that they lack social emotional reciprocity, they have nonverbal communication, or they have relationship deficits, restricted repetitive behaviors or atypical patterns of behavior, including stereotyped, inflexible, restricted behaviors. They can have sensory hypo or hyper reactivity. And again, these lists are a little bit more extensive if you look into the DSM, but they have to have 3 deficits in social communication and a minimum of 2 symptoms in a restricted range of behaviors or activities. Symptoms typically present early in childhood and cause significant functional limitations not explained by intellectual disability or global developmental delay. And autism is typically recognized with 3 levels of severity. So I have this infographic here to give you a little bit of an idea of what those 3 levels are, and so you can pause to read it. But really the important thing to know here is that autism spectrum disorder is named autism spectrum disorder because it is a wide spectrum of presentations, and it is really important to remember that no 2 autistic patients are going to present in exactly the same way. The etiology of ASD, it has a genetic component. It's really important to note that vaccines are safe. We as healthcare providers need to help fight the misinformation out there about the connection between vaccines and autism. There's no known correlation between vaccinations and the development of autism, and so we need to make sure that patients and their families are educated on the safety of vaccines. As far as the genetic component, there's a genetic corollary where we see that patients with autism spectrum disorder, their siblings are 14 to 15 times more likely to be diagnosed with autism than their peers of their cohort. And when we're looking at other genetic disorders like these listed here, one of the most common ones that it has to be ruled out against is Rett syndrome, which we saw didn't make it into the grouping of the broad label of autism spectrum disorder in the DSM-5. Rett syndrome was a separate category. And Rett syndrome is only present in females, but at early ages between 6 and 18 months can have a similar presentation to autism. Teratogens can also be a factor in the causes of autism, and other risk factors include advanced parental age, preterm birth, or low birth weight. hyperbilirubinemia, and siblings with autism spectrum disorder. One of the biggest issues that patients with autism experience is sensory processing. And so 80% of children with autism spectrum disorder have sensory processing problems. And there's two continua of responses that we look at when we look at sensory processing. There's threshold and there's self-regulation. So threshold is the speed of reaction to a stimulus. Do they respond quickly or slowly to a stimulus? How fast is their response? Self-regulation is what is the level of response? Is it under or over what we expect normal to be? Research has demonstrated that children with autism spectrum disorder have greater postural instability when sensory information is less reliable as a result of the sensory processing issues. And this helps understand how the sensory processing then plays a role over in function and the increased prevalence of injury within autism because of increased clumsiness and lack of spatial awareness. Associated problems can include atypical language development, delayed fine and gross motor development, gait and postural control, motor planning or dyspraxia, lack of coordination, and low muscle tone. But it is important to remember that not all patients with autism are going to present with any or all of these things. They can also experience co-occurring problems including intellectual disability, epilepsy, personality and behavioral disorders. Again, not all people with autism are going to experience any or all of these things. Many personality and behavior disorders can be associated with sensory and motor processing deficits that result in frustration, and they're not actual behavioral problems, but rather a result of the sensory or motor processing deficits. The more co-occurring problems that a patient has, the greater their needs for services tend to be. Early signs of autism in toddlers can include delayed or absent joint attention, delayed development of pretend or symbolic play, a decreased response to their own name, an extreme variant in temperament, decreased imitation or gesturing. They can have motor delays, unusual visual motor exploration, and an inability to disengage their visual attention. There's typically not this reciprocity of gesturing or facial expressions that we see in normal child development, and that can be one of the hallmark signs. We also may see signs such as no babbling or gesturing by 12 months. These patients tend to remain nonverbal for a longer period of time. They have an inability to speak one word by 12 months. Inability to combine two-word phrases, not including imitating or repeating somebody, by 2 years, and any loss of babbling, speech, or social skills at any age with the onset of autism. And so we can see that speech and communication can be highly affected in this population. Diagnosis, we should see screening begin at 18 months per the American Academy of Pediatrics. Reliable diagnosis by 18 to 24 months so that we can implement resources as early as possible. Motor abnormalities may be seen as early as 6 months. There is research out of Denmark, I think, that found babies who can't sit up straight when they're put on a lap at 6 months old had a high correlation to the development of autism spectrum disorder. And so looking for those motor abnormalities such as head lag or poor lap sitting, because those early delays may provide a diagnostic clue. And poor motor skills may interfere with the development of social interactions, because if they are not acting on par with their peers, they can't develop the social skills with their peers through interacting with them. Physical therapy role. Physical therapists have a role in recognizing movement impairments affecting muscle tone, motor development, coordination, and motor planning. Recognizing these motor stereotypes as well as any kind of abnormalities of motor control can be improved by consistently practicing observation skills during free play and teaching parents how to practice these observation skills during free play, because we want to break stereotypical movement patterns and teach children how to have their own unique movement patterns. We also want to pay close attention to the presence of their postural reactions. A lot of times a lack of response to postural reactions, and that could just be the sensory processing deficit in the threshold in regards to timing of the response, but they can lack those equilibrium responses. We as therapists want to foster early motor skills, postural control, and object exploration, trying to facilitate walking for environmental exploration and sensory motor play, including things like joint attention, where we are playing with the child, giving dual attention to what the child is attending to. Early intervention best practice. So the child's family is central to the intervention program, and services should include family support and education. Intervention services need to begin before the age of 3 for best outcomes. Facilitating active engagement of the child is an essential priority for all interventions. And targeting joint attention, imitation, and play, because these abilities support the development of language and social function. Remembering that autism is related to motor dysfunction, but it's also related to social and cognitive dysfunction as a result of lack of the ability to interact and play. There are two major categories of intervention that target social communication in the preschool and school-aged kids with autism. The behavioral naturalistic category looks at applied behavioral analysis and using prompting and modeling to engage the child. The goals of behavioral naturalistic interventions are to get the child to follow the therapist's lead, and so you prompt them and model a behavior and get them to kind of mimic it. Whereas developmental relationship category includes imitation but following the child's lead. Behavioral programs are intensive and can be time consuming, and so again, this is one of those resources that we want to be able to implement for the child as early as possible to get the best benefit from it. But if a diagnosis isn't been made, then they can't get those resources, and a lot of times these resources have to come into play at school because of the amount of time that they require. Motor imitation is an important part of learning and development in childhood, and because of the hesitancy to imitate or the lack of natural response to imitate that can be seen in children with autism, there can be a delay in motor development just as a result of that lack of imitation. And so joint play is a huge focus of interventions during therapy to help guide that imitation, whether it's the child imitating the therapist or the therapist imitating the child. It's a really important form of communication in pre-verbal children, but also post-verbal children, and they've found positive associations between imitation and play and subsequent language development in a child that's slow to develop language. So we want to encourage children to imitate our skills early on. Normal development that happens rapidly over the first 2 years of life, especially during the second year. And that's how children learn new motor actions. They imitate the adult movements. And so we can utilize joint play to help get the child to imitate movements and get more on age appropriate level. Overall, gross and social skills are highly correlated in young children with autism spectrum disorder. Motor impairments such as object manipulation, stability, and motor accuracy predicted social function. Restricted play in children with autism spectrum disorder. So deficits in pretend play are related to social and cognitive development, and so that's, again, that lack of imitation limits the motor development, which then limits the social engagement. And so this can lead to activity restrictions and participation limitations such as peer interactions, physical education, and recreational sports. And it can often be due to problems with muscle tone, motor abilities, coordination, motor planning, and just, again, not having learned the motor control through imitation at those formidable years between 1 and 2 to really gain those motor skills. Pretend play is something that comes along as part of normal social cognitive development, and it develops after a child's learned the cause and effect principle, because you have to understand the cause and effect principle in order to really get into pretend play, and it's kind of a natural progression from functional play. It predicts social and language skills in typically developing children, but children with autism exhibit delays in developing pretend play. Play provides a social context for embedding instruction and affords the child the opportunity to interact socially and communicate with peers, caregivers, and teachers. So it's important for us to integrate pretend or symbolic play again, by utilizing joint attention and social referencing, trying to integrate the interaction with other children when possible and appropriate, and even teaching it to the parents and teaching parental scaffolding so that they can build those social interactions starting at the level where the child is and working up to the age appropriate level. One of the methods that we can use for trying to kind of prompt that joint attention, joint play, and pretend play is using the system of least prompts. And it's an example of antecedent-based teaching strategy where it basically has been shown to get kids more engaged with pretend play. And so it starts with you presenting an object and observing and imitating the child before you prompt any play. You just give them something to play with, see what they do with it, and then you imitate that. Then you can move to adding a choice. So giving them the option between playing with a toy or imagining something that they are playing with, or presenting them with two toys and giving them the choice and seeing what they do and imitating from there. And then you can layer it on with modeling the behavior, because they've seen you imitate them. Now they can imitate you back, and that can help to guide the behavior. And then you can also provide things like visual cues or tactile cues with hand over hand, or verbal cues just to give specific instruction, especially as they progress and don't need quite as much guidance. We want to make sure that we increase play complexity as the child progresses, recognizing the difference between practicing a task and perseverating on a task. And if the child isn't demonstrating productive practice, but it's just a repeated perseveration of a motor skill, then it's not actually being productive into the functional blueprint that they need. And so we need to be mindful when we're doing activities with children with autism that we pay attention to productive practice versus perseveration, and engage the children at their level by using imitation and then modeling the higher level of play. Utilize peers to exhibit a higher level of play than the child when that's appropriate. And vocal play, tunes, rhythm, and dance can be highly engaging in this population. Because behavioral issues can be present in the autism population, often as a result of processing issues, whether that's sensory processing, motor processing, or just cognitive processing, we can often utilize positive behavior supports to help create the least stressful treatment session. Some of those can be things like a timer, choice board, a schedule of activities to be done, using first then to reinforce with preferred activities. So basically the whole concept here is really creating a structure, providing clear routine for your therapy sessions, giving the child structure when needed. When they want to deviate off task, giving them the opportunity to get to whatever it is they want to deviate to after they've completed what you want their attention on. So that's that first then concept. So first we will do this, then we can do what you want to do. And then also utilizing modeling, whether that's live or video, and again, trying to look for peers and age appropriate content in what's most appropriate for live versus video, and make sure that you have the patient's attention before any of that modeling, because if you don't have their attention, then you're not doing anything worthwhile. Specific interventions for the autism population can include sensory integration and sensory-based interventions, which really lack research support but have a lot of anecdotal evidence from whether that be therapy professionals or really more oftentimes parents, where they've figured out how to desensitize their child to whatever their hypersensitivity is, or they've found how to increase their awareness when they have a hyposensitivity. And so a lot of that tends to be more anecdotal, but that also has to do with how broad the spectrum is for autism. And so patient awareness, patient mindfulness, and communication are extremely important. Exercise and physical activity has emerging evidence, especially related to sensory processing and being able to improve balance to decrease the stereotypical clumsiness that's associated with autism. And school-based interactive interventions where there are peer interactions can be extremely helpful in this population, including peer modeling utilizing social scripts, story-based interventions, and peer training. And that's going to focus more on the behavioral aspects than the motor aspects of autism. But again, if motor processing is factoring into the behavioral aspects, we can often treat those things in tandem. Because of the sensory processing issues experienced by patients with autism, aquatic therapy has been shown to have significant benefits in this population, especially in regards to behavior during treatment sessions, in regards to not being overstimulated by their sensory environment. The pool just gives a good sensory environment to give the opportunity to play and have social interaction, and encourage those positive social behaviors. It also tends to promote improved sleep following the implementation of aquatic therapy in patients with autism, and an overall improved quality of life. It provides a rich sensory environment for functional adaptation. Patients should learn water safety and swimming skills prior to performing aquatic therapy, but it can also be an area where you can enrich those skills and enhance their safety in the water, and provides fun for a child that can involve peers and family. Just a few important considerations to kind of maximize the effectiveness of your intervention in patients with autism, or interventions in patients with autism, would be to use familiar objects and routines. You want to prepare the child for any changes in routine. Remember, trying to keep as much structure as you can. Follow behavioral protocols. Speak clearly and keep your instructions simple. Encourage eye contact with the child during communication, since this is an area of social deficit that patients with autism typically demonstrate. Structure your environment to support appropriate social skills with peers, and use daily activities to increase strength and functional skills. Our areas of physical therapy intervention in treating patients with autism spectrum disorder are going to be age-appropriate motor skill training. So if there's any kind of developmental delay, we want to make sure that we help them achieving developmental milestones as on track as possible. We want to work on balance and coordination, because balance and coordination deficits are prevalent in the ASD population, especially when those sensory processing deficits are high. Postural control, including strengthening. Once they're able to get in a seated position, we want to work on those righting reactions and equilibrium responses, putting them on unstable surfaces and progressing to standing as much as we can. When they've got low postural tone and don't move very often, we want to pay attention for compensatory movements and try to correct those, and teach parents patient management and positioning and handling techniques that will maximize the appropriate utilization of muscle groups. We want to do functional mobility training and activities of daily living, again, trying to maximize functional independence. Working on motor planning, because that motor processing can be an issue, and dyspraxia can be a symptom of autism. Just planning out motor sequences can be helpful. Physical activity, including leisure and recreation activities, so anything that they want to participate in beyond their ADLs. Motor play and play development are going to be integral components of any pediatric intervention plan of care, and knowing that our goal is to foster strength, coordination, postural control, and balance. Lifespan PT interventions. So our emphases in different areas of life. We're looking at infancy here. Our goal is to foster early motor skills, sensory motor development, and joint attention. In the childhood to preschool phase, we want to develop fundamental skills like running, jumping, hopping, skipping, bike riding. We want to develop body awareness through activities like yoga, which will help enhance proprioceptive awareness, and foster pretend play and physical play in games with peers and aquatic activities. In school through adolescence, we want to modify and adapt motor skill training and work in group exercises so we have more of that social interaction, and foster community participation in meaningful ways, again trying to integrate that social level. And through adulthood, we want to promote group exercise programs supporting a healthy lifestyle and choices.